First of all, I would like to thank Drs. Cush and Kavanaugh for inviting me today to share my thoughts with you about teaching rheumatology in the pandemic. As I was considering this session, I was trying to remember what life felt like last year at this time. In February, we were starting to hear of cases of this novel coronavirus. And by early March, it was clear that business as usual in academic medicine was going to have to change. In March, I was preparing for our annual program directors and division directors retreat, which we hold in Chicago every year. And this is one of my favorite meetings, and I really look forward to this meeting every year. It's a chance for clinician educators, program directors, clinicians, teachers to get together and talk about rheumatology education and our academic workforce. And as I'm sure you're aware, we made the very difficult decision to cancel that meeting. Day by day, more of our institutions enacted travel bans as cases rose at our hospitals, and we were inundated with patients, first in Seattle, then in New York and other metropolitan centers, and then like a blanket over our whole world. Our students were sent home, our clinics were placed on pause, and we were encouraged to do as much work from home as we could, not unlike what I'm doing right now. And we really had to take stock of our essential work and try to figure out how we were going to get it done. It all seemed insurmountable. But like every challenge, you just need to begin. And this is what we did. This is what we all did in our clinics, in our schools, in our hospitals, and wherever we practiced and taught medicine. And it was actually quite simple now that I look back. And I can distill it down in this way. Safety was our guiding principle and continues to be our guiding principle. Is it safe for students? Is it safe for the residents and fellows? Is it safe for our patients and staff? And is it safe for us? Every decision started with this. And I don't have to tell this audience how our thinking and plans have evolved so rapidly. Just keeping up with that is a full-time job. Patient care continued to be a priority, and we had to be very creative to keep our patients healthy and safe without bringing them to the medical center. Initially, we were doing phone check-ins, then our telehealth platforms popped up, and soon we were doing full clinics virtually to keep everyone safe. And education had to continue. We had fellows that had 8 months of training with precious few more months of fellowship to acquire a broad fund of knowledge and patient care skills. And in some places, fellows were covering the COVID services, pulling them further away from their specialty training. How do we keep teaching our students, residents, and fellows while keeping everyone safe? So what has happened in education has been quite remarkable. So here we were. This is our office, our classroom, our clinic. Our job was to figure out how to make that work. We had been talking about telehealth for years, but somehow it never gained any traction. Well, all of that had to change, and very rapidly. Although it opened doors for us to continue our care, telehealth is not without its challenges. The technology can be very difficult, both for physicians and patients. You must have the equipment and broadband access to participate. Interestingly, our pivot to telehealth revealed additional challenges to health equity, as many communities do not have good access to broadband. And as a side note, if you look at those communities that do not have ready access to rheumatology care, these are many of the same communities without access to the internet. This has been food for thought as we think about how our practice is going to evolve in the future. Of course, our faculty and fellows were for the most part inexperienced with the technology and with the telehealth competencies. Yet here we were, teaching rheumatology on telehealth. But we learned. Sometimes it was awkward and bumpy, but we learned. The AAMC quickly put together a document on telehealth competencies, and we were off and running. We now have a framework to assess our fellows and really ourselves on telehealth skills. These included appropriate patient safety, data collection, communication, ethical principles, the technology, and access and equity. There's currently work underway to develop specific telehealth skills for rheumatology, and we look forward to that guidance. And what about education in the pandemic? All of our conferences quickly moved to Zoom, but many questions remained. Can we get our information across in this format? Can we assess our learners in this format? Do we have the right technology? And can our teachers and learners actually use it? How do we manage the loss of the personal interactions, which are so important in our professional development? I think we took a minute to breathe and think about this, but not too long because we really had work to do. And there turned out to be a real upside. Attendance improved. I can tell you that on our grand rounds, we had probably maybe 50% more people attending each week. Barriers to collaboration were broken down, and this turned out to be a massive opportunity for instructional innovation. And I'd like to share just a couple of examples of this to illustrate. Some of you may be familiar with the viral lecture series. This was the brainchild of rheumatology program directors led by Dr. Anisha Dua. One weekend in March, there was an email circulating about creating a lecture series for fellows. And this was going back and forth among many program directors and educators in the rheumatology world. It turned out that many programs had scaled back their didactics, and this was an opportunity to help those programs, to augment the learning for those fellows and even for those faculty and other learners at those programs. Within 48 hours, 21 program directors from around the country volunteered to participate, either present talks themselves or recruit other faculty. On Monday, we brought this idea to the ACR, who immediately agreed to host the lecture series. And we were up and running in just days. By April 6th, we had 3 sessions weekly for 8 weeks in a row. Each session was given by a rheumatology expert, and there were 2 moderators, 1 faculty and 1 fellow. And we really thought that these sessions would be useful for fellows and academic faculty. But what happened next, I do not think any of us would have anticipated. We were planning on a maximum of a few hundred fellows, but ultimately we had almost 2,000 registrants from 55 countries. Word of mouth, social media, emails, and other ways that we communicate using the internet spread the idea of this lecture series far and wide, and it truly went viral. The live sessions had an average viewership of about 450 people, and people continued to access the content on the internet. And the feedback from the program was really remarkable. And there were a few important lessons that we learned that I think will inform how we move forward in the future in terms of our educational activities. Program directors were grateful for the educational support, especially those programs hit hard by COVID. Expert faculty from one institution could share their knowledge with a much broader audience, and all fellows had access to this expertise. I received so many emails from fellows just so grateful for the opportunity to engage with faculty from all over the country. And finally, we broke down barriers. We brought rheumatologists from around the world together on one platform to learn. It was very, very exciting. And when the series was ending, many people reached out and said, we need to keep doing this. So based on the success of the viral series, we put together a working group to develop the VIP series, one for adults and one for pediatric rheumatologists. The concept behind the VIP was to present foundational concept for new rheumatology fellows who would be starting in the summer of 2020, really in the midst of this pandemic. At that time, many programs were still reeling from the COVID surges of the spring, and many programs welcomed the additional curriculum to onboard their rheumatology trainees. This was an 8-week series with 4 hours of instruction each week. Again, the feedback was remarkable, and we plan to continue this program in the upcoming academic year. We have recently launched a third program, which is called the Vital series, and this is a monthly session with a comprehensive deep dive into a complicated rheumatology topic. We've changed the format a little bit. These sessions have multidisciplinary instructors and an innovative interactive design, somewhat different than the Viral and the VIP series. Plans are now underway to continue developing these types of learning activities that will hopefully reach a broad and diverse group of rheumatology learners. And finally, I want to share a recent win for teaching. Here in the Carolinas, we have had the Carolinas Fellows Collaborative, which includes all of the rheumatology training programs in North and South Carolina. We began meeting together in the summer of 2004 with a first-year Fellows boot camp. And since then, our programs have met twice each year. Our last face-to-face meeting was in February of 2020 here in Chapel Hill, right before the pandemic hit. This year, although the program was hosted by the Medical University of South Carolina, we met virtually. And here you can see some of our fellows and faculty meeting together on Zoom for the Carolinas Fellows Collaborative Winter Meeting 2021. We had interactive sessions on numerous topics, including a mini symposium on systemic sclerosis. There's so many faculty at MUSC that are expert in this area. And here we can see a session led by Dr. Ken O'Rourke, a master educator, on the evaluation for crystals by polarizing light microscopy. So we were able to do a lot of the sessions that we have done face-to-face in a Zoom format. And one of the most exciting things that we did, and this was just a week or so ago at our winter meeting, was a ROSCE. Every year we do a ROSCE, a rheumatology objective structured clinical examination. This is a formative learning opportunity for fellows to gauge their competence in common clinical tasks in rheumatology. This year, we did the whole ROSCE virtually on a Zoom platform. 23 fellows, 12 faculty from 5 programs participated. Fellows were assessed in their ability to perform DEXA counseling, manage a phone call from a referring physician, provide recommendations for pregnancy in a lupus patient, read pathology sides, and evaluate radiographs. The ROSCE went amazingly well, and feedback from both faculty and fellows was very positive. I think we were all truly amazed. So in conclusion, I want to just share a few thoughts. The pandemic has really required a very rapid redesign of all of our teaching activities, paying attention to safety, our patients, as well as the educational needs of our learners. Our initial, what I like to call emergency teaching, led to very thoughtful restructuring of teaching activities, including telehealth and online learning platforms. Multiple new and innovative programs have emerged, and I suspect that our experience will likely shape the future of rheumatology education long after this pandemic is over.